So that is a little bit of what I hope to accomplish here today too. A lot of panels can be really the same. Everyone nods and agrees on everything, and that's really not a lot of fun to talk about or to listen to. So really briefly about myself. Again, my name is Mark Binger. I'm a VP of Research at Lux Research, and basically what our company does is evaluate other companies that are kind of in between the places where my two panelists are. So we look at academic research and the startups coming out of universities. They start to get venture funding, and then we start tracking that. And then we help basically the larger companies that are acquiring those companies or partnering with them choose the ones that they should work with and maybe make investments in them and ultimately acquire them, compete with them, partner with them, or even get disrupted by them. My background is also, interestingly, halfway between the two organizations that we're seeing here. I worked at UCSF right across the hall from the Startup Garage, where a lot of really amazing companies are now starting to come out. This is right when it was starting, about 8 years or so ago. And my family background, my mom was a nurse, my father worked at Xerox, and so I've really kind of grown up at this intersection of IT and biotech and health. So I know a lot of times bridging the gap between the two can be a challenge. Just by show of hands, how many of you would say you're from more the medical bio side of things as opposed to the IT side? Okay, wow, that's all right. How many of you are from the IT side? Okay, great. And how many of you feel like you're kind of at home in both? All right, well, that's interesting. So we mostly have a divided group here. So we want to translate that a little bit because as these types of technologies that we've all been working on literally for decades about digital health and new types of sensors and even wearable technologies, integrating those into a business context and making sense of those from an IP perspective is not simple, which is why it's taking so long. So this UCSF-CISCO collaboration is really interesting, and we have two of the key people that will tell us about what they're doing. So we'll spend a few minutes just hearing from them about what the partnership has been working on to date, where it stands, and then we'll come back down here. I will have a few questions for them about what's going well with the partnership, where some of the challenges have been, both technical and business-wise. But then we'll open it up to you. So I hope you'll start thinking now about the types of questions you'd like to ask them, and that will make our 30 minutes, I'm sure, fly right by. So first we're going to hear from Jim McDowell from CISCO, and then from Anor Sawyer from UCSF. And you want to come up one at a time or together?
Yeah, thanks. Well, maybe I'll just introduce myself briefly. And so Jim McDonald, good afternoon, everybody. Thanks for your time today. I'm the general manager of two cloud software business units at CISCO, one focused on IT services and a newly formed business unit for healthcare data and analytics that is really anchored in our partnership with UCSF. Been at CISCO for 3 years. Actually came in through an acquisition of the company that formed the IT Services Integration Business Unit. I ran the Americas as a company headquartered in Vienna, Austria, and was Chief Product Officer. I was there about 18 months, and before that I was 8 years at CISCO, running a number of software business units and some of our proactive services business. And my career has been sort of split between IT and software development, cloud software development largely, across a number of IT services companies.
And I'm Anor Sawyer. I'm an orthopedist at UCSF. I'm also involved in device and digital health innovation. And in the Center for Digital Health Innovation, I lead the strategic partnerships. I also lead the digital health track in our internal accelerator called Catalyst. And I do some advising on outside with incubators and startups as well. I have a couple of things that we've been building ourselves, but such as a virtual tumor board, we can talk about how that feeds into this the seeding of this partnership.
Okay, great. So first I'd like to just find out, how did this idea even get started? Who approached who first? You know, this is almost like the Newlywed Game. How did you meet? And, you know, who approached who, and how did that go?
Well, we can flip the story a little bit if that's okay with you, because we'll get to that. I'm wondering if it would be okay. I always like for Jim to talk about CISCO in the modern era, because I think a lot of people don't have a sense of what CISCO is now. We have our former ideas of it, because it'll start making more sense why, as we felt a need to address interoperability, why we ended up looking in CISCO's direction. Would that be okay with you, Jim?
Sure, yeah, I'm happy to. So many of you think of Cisco as a hardware company, probably a networking company. Many of the healthcare systems around the world run their networks on Cisco gear. Much of the data centers run on Cisco servers. We have a big play in security as an example. What many people don't know is actually if you took the software businesses at Cisco and separated them, it'd be the 5th largest software company in the world. So we actually have a fairly large footprint of software, much of that built organically, much of that through acquisitions. In fact, 14 of our last 15 acquisitions have been software acquisitions, and many of them in this area of data and analytics, and that will sort of surface as we get to the question of how this partnership sort of germinated. So, and Cisco thinks about data and analytics a little differently from some of our peers because we started the network, so we think about things in the furthest extreme, the furthest possible connected device and how you get that data from that device and move it back or interpret and analyze it before you move it back in motion or actually at the device. And so we think about sort of technologies that allow you to look at all of these connected devices which are proliferating. In many industries where we deploy digital technologies, we see tens of millions or hundreds of millions of devices that could actually be remote and mobile, as an example. Sometimes with intermittent network connectivity, so you can't always be assured that you have reliable, network connectivity to that device. And how do you think about data coming off that device that may be just too much data to transmit back to a data center for analysis, or that you need to take immediate action on, right? So the data and analytics that we look at is really encompassed from the point of view of a very broad and hyper-distributed network of connected devices where you need to have people pulled into the process, where you apply analytics and really weave that together into a single integrated architecture. And that's one of the business units. So I'm in that parent business unit. We've been applying these technologies across many industries, financial services, retail, oil and gas, and others. And really through our partnership with UCSF has now been looking at how that applies in the healthcare space. So that's the background. You want to maybe share that?
Thank you, Jim. I just find that fascinating because it's so different than what we think of, or at least I had to go through this exercise over and over when I was convincing my colleagues that I thought this would be our ideal partner. For me, I come at this intersection from the standpoint of being a patient and a family caregiver and also a provider. And the struggles around the gaps in interoperability are extraordinary from each of those vantage points. And the onus of getting the right information to the right place and to the right decision maker falls on the patient. And it's also the patient who bears the consequences if the information's not there. As a provider, I want to make the best decision possible. I can't if I don't have the right information, and it's extremely frustrating to know the information exists, even if it's in Reading and not in my clinic at Mission Bay. And I just can't make the best decision without it. So I'm left with a few not so good choices. Either repeat the study, which is expensive and may expose the patient to more radiation or invasive procedure, or to go without the information, not make the best informed choice, or to inconvenience the patient, delay the decision, have them come back again later. None of those are optimal. And it's an exercise, I just came from clinic to here, and it's an exercise that I go through every single clinic with my patients. Besides just my own personal experiences with it, we live in a very exciting place and an exciting time. We're very busy innovating on the front lines of healthcare, building all kinds of solutions. We're partnering with people outside building solutions. We're continually approached by startups to do validation as well as for domain expertise. So we're in an extremely exciting period of people building point solutions, isolated solutions, shiny pearls, but they're not stringing together yet. And that's a big problem we face. As providers, we want to make recommendations, but we don't know how to hook things together. People come to us to implement these things in our system, and they're really wonderful point solutions, but if they don't connect together, we're going to be really struggling to figure out how to integrate that into our care system. Besides all of the great devices, wearables, apps that are now available outside the clinical system, inside the clinical system, we have the same gaps in interoperability. We have 50 different IT systems that are running in our hospital that are not connected or don't come connected or naturally connectable to the EHR. So for decades, we've been brute forcing those integrations within the clinical system. And unfortunately, they're one-off sort of bridges. So we've been frustrated in trying to figure out how we could make those things scale. Now we have a lot coming at us from outside the clinical system, also wanting to have bridges and integration with our clinical IT systems. And again, these are often one-offs and hard to scale. But we also know our colleagues right down the road in their healthcare delivery system have exactly the same struggles. So we decided that we would try to figure out how do we make scalable interoperability solutions. When we dove into it, we started looking at the cost of interoperability gaps, and it's billions of dollars, no matter which subject you look at. If you just look at the breakdown in the supply chain of pharmaceuticals, $300 billion a year lost because of interoperability gaps, and 300,000 lives lost each year because of missing information or wrong information. So the consequences are huge financially and from a human perspective. So we just decided we were making our attempts at it, but we couldn't, from the front lines, being as informed as we couldn't solve it because we're missing the technology, the capacity from a technological standpoint. So we went looking for partners, which is one of my roles. And as we started looking, I first went out trying to solve my own problems around virtual tumor board. We had a fantastic platform, but it was the aggregation of the pertinent data was the real problem, as is most of the things that we talk about, is getting the pertinent data aggregated and processed to make the data contextualized and actionable. So I went really looking for a partner around virtual tumor board first. When I realized what they were doing at CISCO, I thought, wow, they probably have the capacity to solve this massive problem that's affecting all of us across healthcare, no matter what stakeholder you are. And so we started the discussions there.
Great. So that actually answered my question, too, my first question. So going to what you said about there are pearls, but they're not strung together yet. And it seems like, to take that metaphor, there's sort of a background of pearls being generated everywhere all the time at a really, really rapid rate. And that's been the case for 20, 30 years now, where it's not that this is a problem we're just identifying now, it's that it's been a struggle to connect all those things. So the Internet of Things is sort of big data worse than it was, and now we've got really profusion of devices in the Internet of Things. So how are you addressing this exponentially growing problem, especially around connectivity, because it seems like that would be getting worse faster than it's getting better?
Well, I'll take a start at that. I think it's very important to have a connectivity strategy, first of all, that accounts for the security that's required. It's critical as you look particularly at medical devices or consumer devices, you have the right authentication and security framework in place so that you have confidence that the data is correctly being associated with the patient and so forth, right? So there's a framework that needs to be established from a security perspective. I think secondly is the ability, as I was saying, and we see this across multiple industries, when the volume of data is so great, a strategy that says, I'll bring everything back and establish this massive data warehouse and just churn all the data simply doesn't work, right? So you need a streaming analytics strategy that says, in some cases I need to look at data at rest, some cases I need to look at data in motion, I need an analytics framework I can apply across all that so I can manage the data where it's most appropriate to apply that analytics. And that's really one of the key differentiators as we look at the work we're doing with UCSF that CISCO is able to bring to the table. It surfaced early on in our conversations as sort of, for me, an aha moment that, oh yeah, I see this problem in healthcare I hadn't really had much visibility to or any visibility to. We've been solving it in other industries, and how readily that technology could be applied in healthcare, I think, was one of our discoveries.
And my colleagues, I talk about this of how it all evolved, and there were many, many players at UCSF working for ages in the integration problems. And when we started talking about it and trying to figure out how we could create a partnership around this, one of the key things was, how do we do what's been done in other industries? What we were looking at, how CISCO's allowed other industries to leverage data from disparate sources to transform those industries. We were also very mindful of the unique challenges that we have in healthcare. And my colleagues who've been working at this for a long time in healthcare IT at UCSF, as well as our clinician informaticists, we sat down and we met over and over about, yes, you can do that in other industries, but what about our unique challenges? And I think for a while that's kept us from moving forward because we think we have such special problems. So we would present these things to the CISCO teams in this over a year of evolution of discussions before we ever got to a partnership. And as we would inform them of the problems, they would be extracting from other solutions in other industries and saying, can we apply that there? So you can imagine the security and privacy issues around finance, which is an industry that they've been working in for quite a while. and how we've been able to port those things over to healthcare. We still have unique problems in healthcare. Some of them are cultural, and some of them are technologic. But I think it's really important to talk even a little bit about how do you get these very different cultures aligned around a problem. Because we talk up here now like this is a done deal and this is very exciting, we're on our way, but it did take quite a while for each of us to bring our large institutions along to this concept. Because the idea is basically it's so badly needed, but there isn't an off-the-shelf solution yet, and why not? And so we had to keep working on those issues of why not. We're still in the middle of why not and learning about some things that other people have bumped up against and how can we work through those. I think one difference that we wanted to do was not just aggregate massive amounts of data. We wanted to get the pertinent data to the moment of decision making to make the right choice and hopefully get the best outcome. And we tend in healthcare to use data retrospectively. So we wanted to look at how they've done this in other industries for real-time writing of the course, shall we say. But I think that one of the things we have to keep working through is there are cultural differences, and there are actually legal and structural differences that we have to keep trying to find alignment around.
Yeah, so I'm glad you brought up problems. So that gives me an opening to ask what's going wrong and what do you need help with? And I'd say in particular with the people that you know or suspect would be here in the audience.
Yeah.
What other types of partners and solutions are you looking for? And is there anything that you can offer that somebody, again, who's here might not know about?
Yeah, I mean, I'll tee it up, and then I think you've got some great insights in this from our very first conversations. When we first started talking about this, realized that although CISCO and UCSF are themselves very large organizations, we're humble enough to realize that this problem is too great for us alone to solve. And so we absolutely need and are seeking participation from other organizations that have insights into or want to solve this challenge of interoperability. They may be looking at it from a slightly different lens. They may have a slightly different or a dramatically different problem they're trying to solve. We're dealing with, for example, with healthcare systems in the UK and Australia and Singapore and elsewhere where, although the clinical aspects may be very similar, there are obviously very key differences in terms of the payer models and so forth, which create some very unique differences in how you think about interoperability. So we've always wanted this to be informed from a broad lens and broad perspective, both from other healthcare systems, from other technologies that are part of the solution, because what CISCO will be developing together with UCSF is not the whole solution. It's sort of the plumbing, if you will. It's the gateway that connects all of the data and applies the analytics. So we very much seek and would welcome conversation with others about how you might be able to participate together in this, in helping to accelerate challenges that you're trying to solve in your environment, or technologies that you have developed or are developing that might play a unique role in solving this problem, and how that might be part of a more integrated solution. So.
Yeah, and I think one of the problems along the way was just initially level setting the brain trust. So we spent a lot of time searching through what are the interoperability gaps, because we wanted this to be a function-driven platform, not aggregating massive amounts of data, but pulling data in for a purpose and then getting it to the right place once it had gone through some processing. So by keeping it function-driven, we had to actually define what the problems were and educate our CISCO colleagues while they were educating us about the technological capacities, for instance. So the level setting of the brain trust was very important, and we're still doing it, but we spent a lot of time in the year before we ever signed to try to say, well, what are we trying to solve? And I think that was really important. And so I would consider that just an initial problem, but it was one that we had so much enthusiasm from both sides that just continued to build, that people really wanted to understand. I wanted to understand their front lines. Our whole team wants to understand more from the technological standpoint and from other industries. And there's a tremendous enthusiasm from CISCO to want to understand how to solve these issues in healthcare. So we mapped for months made 6 basic modules of the big categories of interoperability gaps, and we drove use cases through them over and over, and we'd say, we need this end-to-end data journey for a patient experiencing cancer. And we'd map it all out, and their engineers would just sit there and they'd say, they'd draw diagrams, and I'd say, could you just take that from way over here, from prevention all the way over here to end-of-life care? And I'd tell the story, and their engineer would just draw a line through their technological stacks diagram. And it was a fascinating experience, and we continue to try to work that way. So I think a problem has turned into a phenomenally successful working relationship.
Okay, great. So I just want to see, is there any questions from the audience yet? We've got about 10 more minutes. There's one in the back. If you could just come, state your name and company briefly, and then ask your question.
It's a long way from the back of the room. So James Drummey from Murdoch Children's Research Institute in Australia. So delighted to hear Australia mentioned. I'm actually really interested in how you measure success and how you prove the utility. I mean, as you said, it's a huge undertaking, and I know you touched on certain use cases and it being functionally driven. But it'd be really interesting to determine or to understand how you're going to determine what ultimate success looks like and how you would measure that.
Well, I think a couple of things to point out, maybe to set the stage for that, and then I'll let you take up. But first of all, we haven't really described this so well, but it's definitely not meant to replace EHRs. It's not meant to create interoperability within an institution, but across institutions, and be able to access clinical and non-clinical data and do multi-directional exchanges. And so this would rest as a layer in a healthcare delivery system that outside groups would be able to innovate and leverage and do plug and play into that system without having to do their own integration each time they showed up at a healthcare delivery system. And after describing that, I think what would be successful is if we were able to take this NIDIS partnership and create a halo effect of strategic relations around it and create an ecosystem of innovation that would leverage this healthcare platform or this connected platform.
Yeah, I think the open innovation is really key. This is a platform that is intended to allow those that are innovating to accelerate the creation of those innovations and then the deployment of those innovations on a global basis. So the more successful you are, the broader that ecosystem is. Ultimately, it's about the global impact we can have, the patients that we impact, whose lives we impact through the deployment of the technology, and the efficiency in the healthcare system we can create through the implementation of the technology. So it really is intended to have broad global impact through deployment.
And when I talked about that, exactly what you're saying is that we want it to be widely used because we want many, many people to benefit from it. From a provider side, I want the problem of wondering, where's that information to disappear. I want all of that to disappear into the background so that we get to what we call now informed health. So we get the pertinent information at the moment of decision making. And I call it point of choice rather than point of care because the other people making decisions besides the providers are family and patient and payers, et cetera. So at the point of choice, the right information should be there, the pertinent information, and have it contextualized. That to me is success. So in a really simple example, I'm a cancer patient and I am still driving my CDs from one institution to another. Now, there are some solutions that work, but they don't work across all institutions. But as a patient, I want my patients, and I as a patient want to not worry about, as my body moves from point to point in the healthcare system, that my data will also move, because currently it doesn't.
Great, thanks. And another question from the audience? Anyone? I asked you to think of questions. Well, I've got many of my own. We talked a lot about interoperability, not wanting to create yet another just isolated system at a higher level. And there are a lot of platforms that are kind of baking out there. I was just in Expo earlier today. I saw there's a company called Validic that, if you might have seen, they integrate wearables and apps and things like that. They had, I thought, a really interesting approach to integrating non-connected systems. So if you can see a readout on a device, you can take a picture of that with your smartphone, and then that data gets read by the machine and translated up. So what are some of the limits, either technical or business model-wise, that you see to the platform? So would you work, for example, would Cisco work with IBM Watson, or would UCSF and Kaiser collaborate on something? Or what do you see as being the limits of the size of the platform?
Absolutely. So, and by the way, we just this week announced a fairly broad relationship with IBM Watson in our data and analytics group. So, yeah, I mean, this is not the be-all, end-all solution. We don't solve all interoperability challenges. There are so many lakes of data, isolated devices, lack of integration that need to be solved. There will be many of those solved by many pioneering companies, as you described. If you look at Cisco's history, we were founded 30 years ago by 2 employees at Stanford that couldn't send email across campus to one another because their departments had chosen different computer systems, right? And they said, this is crazy, let's invent a way to route traffic that adjusts for multiple protocols, and that created the multiple protocol router. So we think about this very much the same way, is there's going to be many organizations and technologies that solve different aspects of integration. What we want to do is make sure that you can flow that across the different integration lakes, if you will, and make sure that data can be applied in Watson, for example, for analytics capability, and can be universally applied at the point of choice. Yeah.
I also think that aside from the partnerships of partners who might leverage this ultimately, we actually want this to be a universally informed solution and universally applicable. So we're looking for partners way up at the front end of this who can help inform what are their needs. We understand certain needs from the front lines of healthcare very, very well, but there are also needs for payers. There are needs for the big analytics solutions. So we really are throwing the net wide for people to get involved early, because the idea that this becomes universally informed makes it universally applicable. And I think our biggest concern is we don't want people to just assume this is simply UCSF and CISCO. It's really meant to be much broader than that. And I think that we're looking at partners even like Validic, because there are several groups that are doing really nice data aggregation platforms. Some are data visualization platforms as well, and we work closely with Validic. And they're solving pieces of the puzzle, and what we're trying to do is really create the seamless flow across. So it should float all boats rather than exclude certain boats and have people just choose. Some people have asked us, how is this different than the HIEs, which I think are making a little bit of a recovery from their early over-promise, under-deliver. And that's actually going to be a very powerful data source. There'll be a data source and a data user of the platform. So I think if you think about more on the function level, and we talk about our 3 key early focuses are the end-to-end data journeys in chronic disease, which you can imagine is a massive problem in all different sectors. There's also precision medicine, which is going to need to leverage the ability to aggregate disparate data sources and make smart associations out of them, and then drive clinical decisions. And then also care coordination or collaboration. That's another of the top 3 big sectors that we're working in. So by picking sectors that have specific functions, it's helping us inform the product requirements and create a platform that hopefully will be broadly used. But we need to hear from potential data sources, potential data users, to really make it deliver on what we've been envisioning.
Okay, so we have time for one very short question from the audience, if you have any. Anybody think of one? No? Okay, you can always come up afterwards as well and talk to the panelists directly. Otherwise, I think, Jill, are we wrapping up?
I have a quick question.
Oh, sure.
Who let that James Dromey guy in here? I thought we had better security than that.
Well, I think what will be really interesting is to follow up and see how things progress in this area. So maybe we'll do a follow-up report.
Yeah.
I think that
It's a good point, Jill, because
Yeah.
one of the other things besides informing it is we're a living laboratory, so we're going to be moving into proof of concept in just a few months with our first function-driven case around referral management. But I think that's a really good point. We
Yeah,
want to
I
see how
mean,
these things work.
Yeah, we always hear, we always, we hear a lot about new technologies in this room, but to really see them kind of come together, we kept talking about all these different pieces that have to come together, and how we're going to be able to explain that in a setting like this, like how are we going to be able to show that and bring it to life, really. So I'm excited and personally challenged on how I can help spread the word and share. So anyway, thank you. Let's give them a round of applause.